Fantastic. Well, thanks everybody for bearing with us for the last 7 minutes.
It's a really good start, though.
Yeah.
The most
Very good.
entertaining part of the call so far.
Well, it's a good sign that people have stayed online. They obviously think they're going to hear something really good. So let's not let them down.
No pressure. No pressure.
Good. Okay, cool. So yeah, thanks for everybody for joining us this evening. So this evening is an interview with Matt Wallden on the subject of pain. Obviously, my name's Leigh Brand, for those of you who don't know me. I'm going to give you a very quick intro to Matt. He might want to add on top of this afterwards. So Matt is an osteopath, he's a naturopath, he's a Czech practitioner, he's an instructor for the Czech Institute. He is a guitarist. No, well, you are a bit of a guitarist.
I would never claim that.
Editor of the Journal of Bodywork and Movement Therapies. And I'm sure there was one other thing I was going to say, but I can't remember. Oh, and an international speaker and presenter. Anything to add?
No, I think that pretty much covers it. I mean, obviously, you could go into like the father of, 2 kids.
Well, you could.
All that kind of thing. But,
yeah. all round good guy.
Thank you.
The reason I wanted to do this interview was because, for those of you that don't know, Matt recently co-authored a couple of papers in the Journal of Bodywork and Movement Therapies, which you're the editor, right, Matt?
I'm the editor of the rehabilitation section.
Yeah.
So Leigh Chato is the overall editor.
Yeah.
The rehab section.
Okay. So Matt recently co-authored two papers with Paul Czech, who's the founder of the Czech Institute. The first one was called "The Ghost in the Machine: Is Musculoskeletal Medicine Lacking Soul?" And then there was a follow-up paper working with the ghost in the machine. Now, I read the two papers, and as a therapist myself, working with a lot of people in pain, first thing I thought, wow, these articles are fantastic. These are going to help a lot of practitioners and therapists help their clients much, much better. But then I also thought of it from the point of view that people are actually in pain, and I thought people that are in pain need to hear this message as well. They need to understand this because, I personally know a lot of people who are really struggling with pain. They've been and had MRIs, they've had X-rays, they've had ultrasound, they've had, lots of diagnostic things done to them, but they either still don't know what's wrong with them, or they've been given a diagnosis, but the treatment isn't getting the job done. And, it's massively affecting their life. And I can really see them, their life really, really affected. And I thought, these people need to really hear this message, need to hear and understand this information if they're going to get better. So that's why I really wanted to do this interview today. Now, in terms of timing, I think we're pretty relaxed. I mean, normally we would do like an hour of interview and maybe open it up for questions after that. That might be roughly what we're going to aim for, but it might be slightly different to that. So Matt, are you ready for this?
I'm ready. I've just seen messages coming in saying that I'm very quiet.
Okay.
Can you hear me okay?
I can hear you fine, yeah.
Okay. So that suggests that it will record fine. I've just moved my computer a little bit because it was on a kind of basically on my treatment table, so it's got a towelling sheet on it. I was wondering if that might be.
Does it need therapy?
It might. Yeah, it may well do, but I don't know if that's any better for those of you that couldn't hear before. So
you sound a bit louder to me now. So
okay. All right, so yeah, let's jump into it.
Well, what I thought, the question that most people I feel are going to want to hear is, so what do I do to get out of pain? But I think it's important to not ask that question first. I think there's a lot of information that people need to understand before we even get to that question, and we will get there. Yeah. So I think for me, the first question really, Matt, and this might be quite a deep question, but what would be your definition of pain? Because most people just think, oh, my shoulder hurts, that's pain, right?
Yeah.
But it's a lot more than that, isn't it?
It is. Well, pain is a perception, and it's not necessarily an accurate perception. So I think that's something that's important for people that are in pain to understand. Now, in general, pain it's obviously designed in nature to be a warning signal to stop whatever you're doing. So if you're running and your hamstring suddenly gives you pain, then it's a warning sign to stop running. If you put your hand on a hot stove and it really hurt, it's a sign to take it off the stove. So definitely, it has its benefits. And in fact, there's a book that I've got called The Gift of Pain, which talks about, is a doctor who spent a lot of time in India, and he was working with a lot of people with leprosy, and they found, of course, that the tragedy of leprosy is that these people do injure themselves horrendously because they can't feel what's going on in their limbs, and so they mangle their hands and things, and burn themselves and things, and so on and so forth. So in that way, pain could be seen as a gift, and that's why the book is called The Gift of Pain. But of course, if you're in pain, then it doesn't feel much like a gift. So like you said, it's quite a potentially deep question, because pain, I think, most usefully can be seen as a teacher. Mm-hmm. So this is a notion that obviously we teach in the Czech system, and we talk about the pain teacher. And so really it's an indication that your body and the kind of unconscious processes or the automatic processes that go on within the body are giving your conscious mind a nudge to say, hey, there's something you need to pay attention to here. And if we block that with a painkiller, then we're kind of ignoring the pain message, but we are ignoring it. So it's quite important for us to, first of all, understand or attempt to understand what is it that we're being nudged about. And that's where, it gets potentially quite complex.
Yeah.
But also, I think psychologically, it's very useful to frame the pain as something that is constructive. So it's, rather than it being destructive, it's giving you information, it's providing you with insights, and rather than seeing it as an enemy and something we need to get rid of. It's a little bit like the war on cancer or whatever. We don't really want to battle against cancer. We want to understand how to improve health so people don't get cancer. So it's about the mindset, which obviously is really what the papers were about, because we're talking about the ghost in the machine.
Yeah.
So it's beliefs that are underlying people's pain experiences and health experiences or sickness experiences.
Sorry, Matt, just 1 second. So people are still saying they're finding it difficult to hear you. It is on Facebook Live as well. If people go to my Body Check Facebook page, that's BODYCHEK, you might be able to hear it okay on there.
I think those messages about the volume were from previously. They haven't changed at my end. I don't know, maybe someone could...
No, one's just come through.
Oh, has it? Okay.
Yeah.
Okay. All right. Oh, yeah, I see, yeah.
Yeah, some strange lady called Christine.
Yeah. Wouldn't trust anyone with a name like that. Okay.
So the first thing you said there was perception. You're saying that pain is a perception. Can you expand on that at all?
Yeah. So, one of the things that's interesting about pain is that sometimes pain is quite extreme when there's relatively little or even no tissue damage. And sometimes also it's quite common that pain will persist even after the tissue that was originally damaged is healed. So it's about what the brain is interpreting the signals as, rather than necessarily any imminent danger. And so that's one of the kind of important things that's come out of the research around pain neuroscience over the last 20 years or so. Is recognition that pain doesn't necessarily equal tissue damage. And I think for many people that are in pain, that's quite reassuring to understand that. It's difficult to accept that that's the case, because if every time you bend forwards, it feels like your back's going to give you pain, then, oh, sorry, I was just seeing another message coming. Someone's plugged their headphones in and it helps. Okay, that's good. But yeah, so if every time you bend forwards you feel pain, then you're, and let's say someone, well-intentioned therapist at some point has said, oh, well, that's a disc bulging, and every time you bend forwards it's going to, press on your nerve, or it's going to cause pain. Then that's the image that you hold in your head.
Mm.
And every time you bend forwards, sure enough, the pain's there. So you assume it's the disc, and you have a sense of anxiety or fear around that movement pattern. But the reality is, it might not be that disc at all. It might just purely be that in the first instance, yeah, maybe it was a disc. Maybe the therapist was absolutely right. But for some reason, your body's still perceiving the pain, even though the disc is completely healed. So that's an example of where the perception of the pain can not match up to the actual structure of what's going on.
So is that like phantom pain as well? Would that be a similar concept? Because obviously the part of the body is no longer even there, but they're still feeling pain. So for those that aren't aware of what phantom pain is, someone could have like their hand amputated and they're still getting pain in their hand, but the hand isn't even there. Is that a similar mechanism, would you say?
Yeah, it is. It is a very similar mechanism. Yeah. So, what tends to happen is you get these drives into the nervous system from, let's say, the injured limb. Maybe you have had an amputation. And so, of course, that is an injury. Even though it's surgical, it's still an injury to the body. So you're going to get a lot of nociceptive, which means pain drives, going into the nervous system. And what that can do is it can create what's termed sensitization within the nervous system. So essentially, the nervous system becomes hypersensitive to any drive coming back from that injured limb. But the thing is that, of course, after the surgery, yes, it's acutely injured, but as it heals, those drives may still be present, and they still may be perceived by the brain as a painful limb or a painful injury, because often when people have these amputations, it's because they have pain already or some kind of severe damage to the leg. So they may have the memory of that and the drives from that original injury still going to the spine, even though that part of the leg is no longer there, or whichever limb. So yeah, it's a good analogy, and something that perhaps people are more familiar with. The notion of phantom limb pain. Yeah.
So really, just to kind of summarize that part of the question. So what we're saying here, well, what you're saying here is that, let's say you injured your lower back, and there was an actual injury, but actually the tissues have healed, but the pain feels exactly the same. So the actual tissues are completely healed. Now, you might have injured yourself a year ago, but there's still pain there. But actually, there's no tissue damage now. It's completely healed.
They've got a completely functional back.
Yeah.
The nervous system's still telling you that there's pain there because that's the habit it got into, essentially.
Yeah. So again, if I use another analogy, is it a bit like, if you turn your light switch on at home, if you were to turn it off, but yet the electrical charge was still going to the light bulb, would that be a similar analogy to use?
Yeah. Like when there's a delay on the electrical charge, being switched off. So some devices are like that, aren't they? You switch 5 seconds or 10 seconds later, it goes off. So yeah, that's a good analogy. But the problem is that, or the difference, let's say, is that the nervous system can keep that loop going almost indefinitely.
Yeah.
And some of that, again, what a lot of the research over recent years has shown is that some of that is due, or a large part of it is due to people's perceptions again. So their perception of whether there is risk there, whether the tissue may still be damaged. And you actually get what they term a descending sensitization. So it's the anxiety in the mind, or the depression, or the sense of being overwhelmed with the pain in the mind that actually sends messages down the spinal cord and blocks what would normally be a natural kind of shutting down of the pain. So typically when a tissue heals, you get a shutting down of the pain messages. So it's called an inhibition of the pain messages. But when there's central sensitization, or when there's this kind of anxiety associated with the pain, or catastrophizing, or depression, worrying, etc., then those mechanisms in the brain can actually send messages down the spinal cord and block the shutting down of the pain. So you're still feeling the pain, even though the tissue's healed.
Yeah.
And so that's, in some ways a tragedy. And in many ways, it's what we would term iatrogenic. And iatrogenic means, it's a medical term, obviously, which means that it's caused by the medical profession. So when someone, for example, you know, has surgery and maybe they have the wrong kidney taken out and they end up dying, well, that's an iatrogenic death. It's caused by the medical profession because there was negligence there of some sort. Well, the way the research in back pain is going is, and in musculoskeletal pain in general is going, is suggesting that actually a lot of the kind of psychological damage that's being caused by, again, well-meaning therapists saying, you know, this back pain is gonna, you know, we can see from the x-rays that your back is degenerated and that the discs are bulging everywhere and that, you know, you really need to stop your sport. You mustn't bend forwards and pick up your kids. Those kinds of things, which, you know, really impact on someone. Imagine how depressing that would be if you're a young mother or father and you're being told you can never pick up your kids again. So that could bring on the depression, let's say, or the anxiety about picking the kids up. Sometimes you just need to pick your kids up, you know?
Yeah.
Anxieties around it, there could be depression. And that could then drive this ongoing, well, first of all, the inhibition of the pain doesn't happen, even though the back may have healed itself. And I think that's also an important thing to touch on, is that the back is very, and back pain in general is very self-remitting. It tends to heal itself after about 8 weeks in most cases, 6 to 8 weeks. Now there is a percentage, and it's about 10% of people where it doesn't self-heal. So for those people, they obviously need more expert advice and insights. But if you have that kind of mindset, essentially almost forced upon you by a clinician of some sort to say, you know, this is actually worse than it really is, or gives a kind of sense of anxiety to the patient, then that can turn it into a long-term issue. Yeah.
So basically what you've just said there is that you can get an actual damage to tissues which can cause pain. The injury itself, you know, if it's quite a serious injury, you know, you could get quite anxious. You might think, well, will I be able to work? You know, that could put a lot of stress on you. You could become depressed because maybe you're quite active and maybe you want to go out dancing or you want to play sports, and now you're depressed because you can't do the things you want to do. And that actually keeps you in pain, and it's almost like a vicious cycle.
Yeah, absolutely. Absolutely. And that's why it's important for people that are working with these people that are experiencing pain to be as current as they can be with the research and the understanding and the language that we're using and so on. So, you know, it's very easy to slip into the old language of talking about, you know, let's say, degeneration and those kinds of terms which seem very negative and very like a one-way street. I always try to explain to my patients that, you know, you find degenerative changes in the spine or in the hip or in the knee pretty much from your teenage years onwards. But first of all, it doesn't mean that there's going to be pain there. But second of all, it doesn't mean that it's a one-way street. The body's constantly healing itself. And, you know, there's a lovely research study done on quite a small group. It's only about 30 people, but they were hip surgery patients. So they were due in for osteoarthritis, but they had osteoarthritis and they were due in for hip replacements. They're pre-surgical. So that means that they're quite extreme. You know, they've got to the point where the doctor and the surgeon have seen them and said, yeah, you need surgery. So they're booked in. And I don't know how big the original cohort was, but they asked this big cohort of several hundred people, would you be willing to see what the natural course of the disease is, the degeneration? And 30 people volunteered. I think there might have been 31 actually. And across 10 years, 16 of them got completely better. Right? And the whole point was there was no intervention. So they wanted to see what happened. And of course, most people, particularly with osteoarthritis at the hip, it tends to be an older person's issue, not necessarily particularly old, but middle-aged to older. And the assumption is that it's a one-way street. It's going to get worse and worse and worse until eventually you need your hip replaced. But the reality is quite different if you actually, you know, let nature take its course. So then if you could build into that some positive reframing of the hip and to build strength around the hip and better function of the motor control around the hip, and look at the diet to reduce pro-inflammatory factors and to work on the emotions and the beliefs around the hip. Well, imagine how many of those 30 would then get better. People left to their own devices. They weren't changing their lifestyle. they weren't doing any kind of program. So I think if you can create an empowering program for someone, that's bound to have a more positive effect than if you just leave them to carry on. But even in that situation, more than half of them get better. So if you've been told you've got degeneration, or that your spine's worn out, or that your knee's worn out, while you're alive, you're adapting. And I think that's really important to understand. That's what we call in exercise the SAID principle, the specific adaptation to imposed demands. So if we can create the right demands on the tissues, then we can make them adapt in the way we want them to in many cases.
So what I hear you saying there is that for people that are in pain, I guess be careful of what you hear from your therapist, because that could actually be prolonging your pain. And to believe that someone's in a pessimistic position is actually not going to help their own pain.
Yeah, and there's a balance between pessimism and realism. I think that there, of course, are situations like we're aware of where you've got a surgical situation. Perhaps there's compression on the spinal cord, and that could cause long-term damage to the central nervous system. And so, in those situations, you don't just try and use positive mental attitude to get it right. You need to have that decompressed. So, for the patients, they really need to find someone that they believe in and that they trust in and that they know is keeping up to date, and that they have a good rapport with. And if they start to hear language that's quite negative, then I would potentially seek a second opinion or do your own research on the internet. There's lots of great information, of course, available these days on the internet, and good groups on Facebook about pain neuroscience, where it's not closed shop and healthcare professionals. It's actually for people experiencing pain, and of course you get healthcare professionals involved there as well. So you end up with a good mix of people's experiences, both from the actual experience of the pain, but also from managing pain patients. And so those are resources I would encourage people to seek out.
Cool. So one of the things that we have been discussing is tissue damage. Now, obviously, in most instances, pain is going to begin from some kind of tissue damage, whether it be a disc in the back or tendon in the shoulder or whatever it might be.
Sure.
I know, because we've spoken about this before, there seems to be a lot of people in our profession that are now saying, well, posture and biomechanics have actually got nothing to do with pain. And obviously, as CHEK practitioners, we actually spend a lot of time assessing someone's posture and biomechanics and correcting it. So what would you say to people that are in pain, that have been to see someone or have spoken to someone, and they say, well, there's no link between posture and pain or biomechanics and pain? What would you say to those people?
Yeah, I'd say that, again, they need to be careful of those kinds of practitioners because that's someone who's taking quite an extreme view, and who's perhaps misunderstanding the literature, because the literature tends to point more towards persistent pain not being related or not being statistically significantly related. So, when we're looking at statistical significance, we're trying to establish whether or not there is a probability greater than chance alone that this specific thing we're looking at, let's say posture, is contributing to the pain. Now, in persistent and long-term pain, then it's less likely that the posture is a key driving factor than things like beliefs and other lifestyle aspects, which I'm sure we're going to come on to in a moment. But for someone who's acutely injured, then certainly biomechanics and posture are very important. But even for the longer term patients, I would say that postures and biomechanics are still means, so working with those are still means of helping the patient to feel better about themselves, to get them moving again, to give them very specific goals, which helps with compliance. So I think there's many good reasons to use posture, just purely looking at it mechanically. But if we were to take posture more holistically, then posture, there's plenty of research out there which shows that posture is directly correlated with mood. So for example, if you're depressed, you'll tend to have a forward head posture, rounded shoulders, increased thoracic kyphosis. Okay, you tend to adopt that posture. equally, if you adopt that posture, you have a greater propensity to depression. So it's a bi-directional thing. So if we say posture is not important in pain, but depression is, well, now you've got a problem, because depression and posture are linked. So if you say posture is not important, well, you can't have it both ways. So you have to, and so my view would be, yeah, of course we can work with posture. It's something we can work with. It's something we can be effective with if we're using the right tools. A lot of the kind of critiques of posture are from research where you're getting, for example, a manual therapist trying to mobilize someone's spine to change their posture, or do a passive technique to the individual. And whilst that certainly can be reassuring and certainly can feel good and certainly can be beneficial, the challenge with it is that it's not changing the way the person's using their body. So the beauty of, I think, the check approach, which is of course what we do, is that you give people tools to strengthen the muscles in their new position, to self-mobilize the joints. So I think A.L. Liederman makes the point that, most people would only go to, say, an osteopath or a physio once a week at the most, maybe twice a week. So let's say you're getting a 20-minute session or a 30-minute session with them, which would be fairly standard. Well, that's less than an hour out of 168 hours that you're getting this influence to try and straighten your spine, let's say. So it's no real surprise that doesn't have much of an effect, if any effect, on posture, and the research kind of shows that. But if you give someone stretches and mobilizations they can do every day and exercises they can do every day, then first of all, they're independent. They're no longer dependent on you as the practitioner. So it's far more empowering for them. But also it means that they're going to get a much better adaptation and change to their posture in the direction of correction, let's say, in an optimal direction. And that's what we have done for many years as CHEK practitioners, and we measure it all consistently, week in, week out. And what you see is almost invariably the posture moves in the direction that you're trying to stimulate it. So again, it's really important that when we're talking about posture, that we're using the right tools for the job and that we're putting it in the right context, which is a holistic context.
So just taking that a step further, let's imagine someone isn't in pain. How important would it be to have good posture and good biomechanics to try and prevent pain?
Well, almost equally as important as what we were just discussing in terms of getting out of pain, because the reality is that we live in a four-dimensional space-time environment. So what that means is we've got 3 dimensions of space. Then we've got the 4th dimension of time ticking along. And it's well established that if you, for example, were to slump forwards, so that's movement into the sagittal plane, so moving forwards in one direction, that puts stress onto the ligaments down the back of the spine. And we know that if you hold that position for between 3 to 7 minutes, you start to get what's called creep in the connective tissues in the spine, okay, in the ligaments. Now, those ligaments are designed to hold the spine in place and to provide information to the nervous system to tell you how you're moving through space and when there's likely to be stress coming onto the spine, and therefore which muscles to activate. So if you sit slumped all day long, then you get creep and stretch into those connective tissues. Well, then that now means that the information coming back to your nervous system is compromised. It means that your muscle activation is compromised. And there's plenty of research on this. So, when you see that, then suddenly it becomes really important that posture is optimized. Because, well, first of all, your injury risk goes up. But second of all, your ability to perform at your optimal is compromised the moment that you move out of optimal posture. So a real simple thing that people can do sat in their seats while they're watching this is just to deliberately slump and to make a gun with their fingers and try turning as far as they can with the slump. So that's you've slumped, you've put tension into the ligaments down the back of the spine, you have moved into flexion, and what that does is it limits your range of rotation, okay? But if you sit upright and rotate, now suddenly you get a much bigger range of motion. So if you imagine a tennis player or a footballer or a golfer where you need to use rotation to kick the ball or to hit the ball or whatever, then the moment you have poor posture, your posture starts to move out of optimal and become, let's say, very kyphotic, well, now you've compromised your ability to play your sport. So your performance isn't going to be as good. You're more prone to injury. So, whichever way you slice it, it makes sense to work towards optimal posture. And my view has always been that I want to help people to realize their potential. So I'm not really about getting people out of pain. That's part of the mix of reaching your potential. But it's not, getting out of pain is not the full story. We want to get people to focus on what their goal is beyond the pain. What is their ultimate achievement they want to create with their life? And when we do that, then we're focused beyond the pain and certainly managing the pain and working through the pain, but improving function and working towards this goal is a much better psychological strategy than just simply trying to get rid of the pain.
Gotcha.
Yeah.
So if there's time, we might come back and talk a bit more about how people improve their posture and biomechanics if we get time. You've mentioned central sensitization of the nervous system and that increasing or decreasing the threshold to pain.
Yes. Yeah.
Can you explain what things can cause sensitization of the nervous system?
Yeah. Well, there's many things that are well documented to cause it. So there's things like irritable bowel syndrome is very well recognized to cause central sensitization. Not necessarily in all cases, but in many cases it can cause this sensitization. Then there's several other different medical conditions. So TMJ dysfunction, that's jaw joint dysfunction. Tension headaches is another one. What's called primary dysmenorrhea, which is essentially period pains, is another one. Interstitial cystitis, so that's recurrent bladder infections or apparent bladder infections. There's restless leg syndrome. There's multiple chemical sensitivities. There's lots of different syndromes which are, actually fibromyalgia is another classic one, and chronic fatigue syndrome. So there's many, and there's a lot more that I could list, and that you can find again on the internet if you look it up. But when you look into the physiology behind it, what you find is that whenever there's an afferent drive, so a sensory drive coming back from an organ that is expressing pain or irritation in that organ, then if it's short term, it's probably not going to create sensitization. But if it's long term, it's almost certainly going to sensitize the nervous system, and you may not even feel pain initially. One of the original thoughts behind central sensitization is that you had to have pain to initiate it, and then maybe something like irritable bowel syndrome or one of these other conditions we mentioned might perpetuate it or accentuate it. But the research that's coming out more recently is pointing to the likelihood that just multiple drives and repetitive drives into the spinal cord are sufficient to create sensitization. Okay, so the reason that's important, if we were to look at it, get a practical example of that. If you had, let's say you had two footballers, could be male or female footballers, doesn't really matter, and they both go in for the same challenge. They both take a knock to their right knee. Okay, if one of them has, let's say, prostate issues or uterine issues, and therefore the cord is sensitized in the lower lumbar region, then they're much more likely to feel quite significant pain from exactly the same injury than the other one who has no prostate or uterine problem. And so, the guy with the or girl with the sensitization, they're going to think this is a really serious injury. They're going to get really anxious. They're going to get depressed about the fact they might not be able to play the rest of the season. Everything's going to kick in, which, when I say everything's going to kick in, what I mean is they're going to feel more pain. They're going to get more anxious, potentially get more depressed, and that's going to increase the sensitization. And so now they end up spending maybe 6 months or 8 months or a year recovering, maybe not ever recovering from it. And the first person that didn't have the bladder or uterine or prostate problem, whatever, they might recover in 4 weeks, 3 or 4 weeks. So the point is that it lowers your threshold to pain. So you feel pain sooner, you feel it worse, it feels worse to you, and it goes on longer if you have central sensitization. But the sensitization isn't necessarily coming from the pain in the first instance. It can be there due to visceral or hormonal or emotional factors driving it.
So, are there any kind of lifestyle choices that could cause sensitization?
Yeah, there's certainly lifestyle choices that will contribute to that. So I think anything that's pro-inflammatory in your lifestyle, so eating pro-inflammatory foods, getting insufficient sleep, which keeps you in obviously a fight-flight state for too long, and when you're in a fight-flight state, you're more pro-inflammatory. Having a breathing pattern disorder takes you into a fight-flight state. So anything that takes you into fight-flight takes you into an inflammatory state. So essentially, not enough sleep, not enough rest, not enough downtime. Those things can all drive inflammation. Dehydration can drive inflammation as well, because one of the things we know at the cellular level is that when a cell is hydrated, it goes anabolic, which means it starts to repair itself. When a cell is dehydrated, it goes catabolic, which means it starts to break itself down, which is essentially the inflammatory process. Okay, so hydration is really important. I mean, there's many things. Obviously, there's certain things in nutrition that are more pro-inflammatory and some that are more anti-inflammatory. So thinking about how you engage with your food is really important. Yeah, I mean, there's many different ways to work.
Are there any particular foods that you might suggest to people are particularly inflammatory?
Yeah, I mean, actually, when I first trained as a naturopath, we were really taught that meats were pro-inflammatory and vegetables were anti-inflammatory, and fish was anti-inflammatory as well. But that's not all that correct. But secondly, you know, there's lots of nuances to it. So first of all, if you eat farmed fish, then they're quite pro-inflammatory. They have high omega-6 levels, not the high omega-3 levels you find in wild caught fish. Secondly, meats are not that pro-inflammatory if they're grass-fed meats, but they are if they're grain-fed. So if they're more commercially farmed meats, then yes, they can be very pro-inflammatory. But it's actually the grains that create the pro-inflammatory environment for the animal, and then you eat the animal that's inflamed, and that creates inflammation in you. And just the same way that if you feed animals grains, they get pro-inflammatory. If you feed humans grains, they also get pro-inflammatory as well for a myriad reasons. So I'm not saying you need to cut out all grains, that you need to cut out, you know, all commercially farmed meat, but that would be a good start if you could do that. So sugars can be quite pro-inflammatory as well, as can caffeine, partly because they stress the cortisol levels. So cortisol is actually, interesting enough, cortisol is anti-inflammatory in the first instance. When it's first secreted, it's like cortisone, like a cortisone injection. You know, when people get injuries, they might have an injection. So acutely, it's anti-inflammatory. But the problem is if you keep getting those injections, metaphorically, or you keep exposing yourself to cortisol, then the tissues start to weaken and you get a pro-inflammatory state. So the tissues are more prone to breaking down. And that's a very common situation in the modern environment. So yeah, there's a few things there.
What about alcohol?
Yeah, alcohol can be very pro-inflammatory as well. I mean, alcohol itself obviously is a toxin. Ethanol is a toxin which the liver has to detoxify, and often alcohols are grain-based. So again, you've got the grain element there. They dehydrate you. So of course, if you're dehydrated, then we know that takes you pro-inflammatory. They damage the gut lining. So that's how they're absorbed, is by literally burning their way through the gut lining. And so that can create an inflammatory response in the guts. And it also can therefore impair absorption of nutrients. And of course, to rebuild damaged tissues, you need to absorb your nutrients. So if you've got a damaged gut lining, then that's potentially going to compromise your ability to heal. Well, it's not potentially, it's going to compromise your ability to heal. And the other thing is, when you have a damaged gut lining, which, you know, is caused, actually the number one cause of a damaged gut lining, or what's called leaky gut, is stress. So, you know, look around you to find someone who's not stressed in this day and age, particularly in the symptomatic population. And that's pretty difficult to find people that aren't stressed. So as soon as you've got stress, your ability to digest is going to be compromised, and the chances of getting a leaky gut are increased. And of course, the longer that stress is perpetuated and the more severe the stress is, the more likely you are to get the leaky gut. But alcohol also causes a leaky gut. Non-steroidal anti-inflammatories also contribute. And there's many other things as well, from food intolerances to dysbiosis or imbalance in the bacteria in the gut. So those are all examples of issues with absorption. But if you have an issue with absorption like that, a leaky gut, well, what that does is that it means that your immune system goes onto red alert, because you're now absorbing macromolecules across the barrier that's designed to protect the blood from the food that you're eating. Normally, the food will stay within the small intestine until such time as it's broken right down to its constituent parts. When you have a leaky gut, you get undigested food particles crossing into the blood, and then the immune system goes crazy, and you start to get multiple allergies and multiple chemical sensitivities, for example, which is one of the symptoms of central sensitization. So that excites the immune system, and the immune system, of course, is basically one of the key functions of the immune system is to go around and gobble up bacteria, viruses, in this case, immune complexes from the foods that have come through, but also tissue debris. And so you can have a more pro-inflammatory state as a result of the immune system being sensitized. You know, just like the way your whole body aches and feels sore, and old injuries start to get sore when you get the flu. Well, that's the same process. If you've got a leaky gut, you're likely to feel aches and pains around the body because the immune system is sensitized.
Okay, great. So one word answers. So yes or no. So would these things again cause central sensitization? Cigarette smoking?
Yes.
Mercury fillings?
Yes.
Most commonly bought toiletries?
Yes.
Okay, good. I made
most commercially farmed foods. Yes.
Yeah.
I mean, most processed foods. Yes. And so, you know, of course, they're not listed in the literature at the moment as things that cause sensitization. Well, some of them are, because multiple chemical sensitivities, you know, of course, would come in under that banner. But the challenge with all of those things is that, so for example, you know, I've mentioned commercially farmed foods or processed foods, they're full of additives, and most additives, or high percentage of additives at least, are pro-inflammatory. They inflame the digestive tract, so that you go straight into that process that we just talked about of a leaky gut, inflammation. And then one thing we didn't discuss in that little section is that when you've got a leaky gut, of course, the gut itself is inflamed and it's painful, so it's sending drives into the spinal cord, and that itself is causing sensitization in the spinal cord, and compromising the ability of the muscles which sit over the gut to stabilize and to perform to their potential. So now you're losing some of your support around the spine, or compromising it at least, as well as having the pro-inflammatory state, as well as having the increased propensity to pain messaging through the nervous system. So it's a real bad idea to eat unhealthily, let's say, particularly if you've got pain or if you want to avoid pain.
Cool. Okay. So I think we've covered that one. Now I'm going to probably ask you what might be a controversial kind of question. So in your article, you discussed about people's subconscious behavioral programming and how it affects their choices, which I guess kind of leads on to what we were just talking about. Can you explain that in more detail?
Yeah, of course. Yeah. So it's a big topic, obviously, and depends how deep we want to get into it. But fairly simplistically, most of our behaviors and habits are subconscious, or unconscious is probably the technical term for it. And so, and that's a good thing, because if we thought about everything that we did, if we thought about how we breathe and thought about how we digest and thought about how we put our clothes on, how we drive the car, then we wouldn't be that effective at life. So once we learn how to do something like ride a bike, drive a car, work in a clinic, work in an office, touch type on a keyboard, that those processes become unconscious. So we don't have to consciously think where the letters are on the keyboard, or consciously think about how to balance on the bike or indicate in the car. Those become unconscious. But the important thing is that somewhere between 95 and 99% of our function, of our cognitive function, is unconscious. And within that, you've got the beliefs and values of your culture that were programmed into you in your formative years. And so whilst the conscious mind can often perceive things and say, oh, that's I didn't mean to do that. Like, for example, I meant to train today, but I forgot, or I got too busy with work, or I made an excuse, whatever it is. Well, that's probably a lot of unconscious programming talking to you, saying, well, we need to earn more money because perhaps as a child that was the situation at home. It could be that you need to be a good what's the term, the Protestant work ethic. To be a good person, you need to work hard, so you stay at work an extra hour instead of going to the gym, when in fact the research shows if you work less, you're more productive. They're actually trialing it in Sweden at the moment, that they're having four day work week, and the productivity has gone up, right? So that's an example. And also, the number of hours you work. I was aware of research many years ago that was saying that anything beyond 8 hours of work in a day and the productivity actually drops. So doing 12 hours, you're going to get less work done than if you do 8 hours. Which seems counterproductive, but the thing is, because you're going to finish, because you can relax afterwards, you stay focused within that block of time. And I've seen more recent research that says it's actually shorter than that. It's maybe 6 hours or 5 hours in the day. So I'm just trying to think where we're going with that. So from an unconscious perspective, we're programmed with these ideas about work, about empowerment or disempowerment. And this is obviously a very important one, because one of the things that we know about exercise, for example, is that it's one of the most effective forms of medicine for pretty much everything. It's as effective as the best statins, but without the side effects. It's as effective as the best diabetes medications, but without the side effects. It's as effective as some forms of chemotherapy. It's very effective for depression, and in fact more effective for depression than most antidepressants, but without the side effects. And the same for low back pain, right? So exercise as a broad spectrum medicine is absolutely incredibly potent. But the problem with it is that people don't do it. And why don't they do it? Well, you have to ask, well, what is it about the way we're programmed that stops us from going out for a run, or going out for a walk, or going to the gym, or playing a sport? And when you look at the prevailing belief systems in society, what you find is that, of course, in the UK, historically, it's a Christian society. And you could go to different countries and you find different religious histories. But for much of the Western world, there's a belief system in a God that's outside of the individual. So God is in the sky somewhere, or in Mecca or wherever they might be. But God is somewhere outside heaven, nirvana, whatever. So the problem with believing that is that puts the power outside of you as the individual. Okay, and actually our whole societal structure is based on that. So in a business, you have the God at the top. He's the CEO, or she's the CEO, and the person in charge that makes all the decisions can hire and fire you at the drop of a hat. In medicine, you have the doctor who is going to diagnose what's going on, is going to tell you, give you your kind of life sentence. You're either going to survive this or you're not going to survive it. And I can get you better with this medicine, with this magic pill, but you have no control over it. I'm in charge here. And so you can see the reflection of the religious modeling in society is there in the different societal structures that we have. The problem is that when you imagine that there's a father or parental figure as a god in the sky, then what that does is it forces you into a childlike position. And so if you treat someone like a child, do you expect them to behave like an adult or behave like a child? So do you expect them to take responsibility for themselves or to not take responsibility? And of course, you know, the answers to those questions are fairly obvious. So now you could speak to anyone about this and they say, well, I don't believe in God, or I don't, I'm a scientist, or whatever it is. But the reality is that actually most people, first of all, the statistics show that most people believe in a supernatural entity. Particularly, interesting enough, if they're primed with questions around death, then even hardcore atheists start to answer them as if there is a deity or a supernatural existence. So it's quite interesting because, there's clever techniques where you can tap into people's implicit or existential kind of anxieties, essentially dying. Okay. And the point is that everyone, the phrase, there's no such thing as an atheist in a foxhole, kind of captures it beautifully, because the moment you really concentrate and think about the notion of death, then suddenly it's like, okay, I think and I hope there's something beyond this, right? So it doesn't, and when I'm speaking to other healthcare professionals, I always say it doesn't really matter what we think as healthcare professionals. What it really matters is what the individual with the pain or the illness thinks. And as I say, most people do have some belief in something. Most people don't really know what to believe, but they don't believe that there's nothing beyond this life. So now it doesn't take many generations back. It only takes 1 or 2 or 3 generations back, and pretty much everyone, let's say in the UK, would have been a God-fearing Christian. So they really would have believed in this notion of an extrinsic power source. But the interesting thing there is that, let's say it was our grandparents or our great-grandparents, they would have been programmed into that way of thinking when they were little kids, okay? And your conscious, cogent mind, your ability to question things, doesn't engage until you're about 12 years of age. So by the time you're 11 or 12 years of age, you're already programmed. So you can use the remaining 1 to 5% to question it and go, well, that doesn't make sense to me consciously. But the unconscious is totally sold on the idea. Okay, so that's, let's say, your great-grandparents. So they then train and socialize your grandparents, and then your grandparents do the same to your parents, and your parents do the same to you. So ultimately, pretty much everyone in society is being programmed with the prevailing beliefs of that society over the prior 3, 4, 5 generations. So I think that's one of the solutions, at least, or one of the answers to why people, despite knowing exercise is the best broad spectrum medicine for them, they don't do it because they don't feel empowered to do it. It's not been given from someone up there. They actually have to engage in it. They have to take responsibility for themselves. And they can't quite believe that something that they could do could actually make that much difference.
Yeah. I'm just aware that the sun's going down my end and I'm slowly going into darkness. Luckily, I've got my iPad. Let me just turn my light on, actually. It might help. I know I look better in the dark. But
yeah, go for it.
That's slightly better.
It is.
Okay, so let's put something to you. So let's say someone grew up in quite a large household, maybe 5 kids. Someone grew up, they might have been the middle child, and they grew up kind of thinking they didn't get any attention.
Yeah.
And it might be, as a child, what they did to get attention was to be naughty, maybe. Mm-hmm. Is there any way that you could see, maybe as an adult, how that might manifest itself as maybe pain? Or is that a bit far-fetched?
No, I don't think it is far-fetched. Because obviously, naughty is a relative term, but being naughty is, often comes with guilt or with shame. And so these are strong emotions that can cause descending sensitization of the cord, and stress, So, one of the things we didn't really mention, we mentioned it a bit, but stress or HPA axis dysfunction. So the HPA axis is the technical term for how we feel stress. It's the hypothalamic pituitary adrenal axis. So that, when we perceive a stress, then those glands all get involved to ultimately produce adrenal secretion and cortisol secretion. So you get into the fight-flight state. But overexposure or activation of that system across a period of time is definitely one of the things that can drive central sensitivity. There's plenty of research on that. So the interesting thing is that it could be from that person's childhood and the way they've engaged with life, that they're a bit naughty, they're a bit of a risk taker. Maybe they've hurt some people or done some wrong to people, and they've got some guilt and some shame around that. So, but just the stress of doing something like that is challenge enough.
Yeah, I guess I probably didn't put that to you quite as I meant it. So I'm thinking someone grows up not feeling they got the attention they should have done.
Okay.
That's kind of programmed into them as a child.
Yeah.
And then as an adult, they think, well, I need attention somehow. How do I get attention? I know what, and this is all going on unconsciously. I know I'll create a lifestyle that means I'm in pain, so I get a lot of attention.
Yeah. Oh yeah, you see that a lot. I mean, that's something that has been observed in medicine for many, many years. And, probably the first time I heard it being talked about in any detail was Caroline Myss talking about the idea of woundology. So people comparing their wounds, and the idea that there's a kind of currency around that, and you see it socially the whole time. People, getting to know each other socially and chatting about what's going on in their lives, and someone says, oh, it's been a bit tough. I went through a divorce last year, and oh really, oh that's terrible, yeah, my mum died last year, and that was tough as well. And then they go, yeah, well, I remember when my dad died, and that was really I can relate to your challenges with your mum's death, because when my dad died, this happened and that happened. So this is comparing wounds. That's one way to get attention and to try to essentially sort of, I guess, getting attention is the best way to describe it, but it makes the person feel validated because they've suffered more. And again, when you go back to digging down to where that comes from, well, Christianity is all about, who can suffer the most, because that somehow that's what Jesus did, and that's somehow honorable, that if you can suffer, then it makes you a good Christian kind of thing. And that's a deeply embedded concept that may not be consciously recognized, but it's part of the whole story that we are led to believe is honorable and virtuous. So these themes play underneath the conscious the whole time. And there's many other reasons that people may play that game. And of course, the medical term for that is Munchausen's. And you can also have Munchausen's by proxy, which is where you hurt other people or imply that other people are unwell so that you get attention. So yeah, for sure that could be.
So I'd imagine, people might be watching this are in pain.
Yeah.
And they're saying, well, don't be stupid. I wouldn't cause this on myself. What would you say to those people?
I would say that of course you wouldn't do that to yourself consciously, but to take some time to meditate, and I use that term kind of loosely, because I think some people think of meditation as a discipline where you sit in front of a candle, but I'm talking of it in terms of take time to contemplate, let's say, and building quiet time regularly into your schedule, into your routine, so you have time to really contemplate and think, is there a way that this could be me calling for help, me calling for attention? And interestingly enough, one of the things that has been shown to really help people with persistent pain is actually meditation, or what's termed mindfulness. They tend to call it mindfulness in the medical literature because it's more of a fashionable term than meditation at the moment. But essentially, it's the same process. It's taking time to clear your mind and to not think about anything. But you may have a theme behind what you're going into the meditation with. And that's something that obviously we train people in the check system. But just to clear your mind, often answers will come flooding in because you're not clouding your judgment with your conscious thoughts. So the skill of meditation and the skill of mindfulness is to be able to drop the conscious mind and to just be at peace in a that's often where the unconscious will rise up, and you'll get insights, and you get sort of what the Japanese called moments of kensho, something that perhaps drove the situation that you're in earlier in your life. Yeah.
Sorry, Matt. Just connection was a bit dodgy there. I think we just about got the message. So
okay.
So another thing that that you spoke about in the paper, and something that we obviously talk about a lot as check practitioners, and I guess it's the question is, you spoke at the beginning about why we get pain. It's a warning sign. But if someone's got persistent pain, what could that potentially be trying to tell them?
Yeah, well, I would say that persistent pain is normally telling you need to dig deeper and find out what's driving that. And it probably is something unconscious rather than conscious. And it's probably something more subjective than objective. So it's probably something that's more belief related or experientially related. So for example, if you've got an inflamed digestive system or an inflamed uterus or whatever, and that's kind of happening below the radar, then you may think that's got nothing to do with your pain, let's say with your neck pain. You could have issues going on low down in your system, and you think that's got nothing to do with your neck pain or your shoulder pain. But actually these drives, first of all, they can spread up and down the spine, which, I don't mean that to sound sort of fear-mongering or trying to worry people. But the point is that any drive into the spine can sensitize the spinal cord, and particularly descending drives. So if you start to get anxious around your pain, or you're, just fed up and depressed with these constant bloated stomachs that you get every time you eat a meal, then those things are the things that are likely to be perpetuating the pain and creating a chronic situation. Or chronic is probably not the right word to use these days, but persistent is more favored, because chronic has an implication that it's bad, but it really just means chronicity, that it's been there for a long time. So, you can go and get temporary relief from injections or from, good manual therapists can make it feel better, and maybe, some exercises may help, but they're only a small part of the picture. You really need to be looking holistically at your hydration status. Are you getting enough daylight? Are you getting enough sleep and exposure to the dark? You're getting a balanced diet that's non-inflammatory. How are your thoughts? Are you having time to meditate and to have self-time? Are you exercising? These are the kinds of things which are, all fairly basic, and really most people know that these are things that are healthy to do. It's just they often are not making time for them in their life, and they don't see necessarily the connection with their pain. So I often explain to my patients that it's a little bit like the British cycling team, and the way they use the concept of marginal gains to improve their performance. So they would make sure that they slept at the right time, and they make sure that they got their nutrition spot on, and they look at every little factor, to the degree that they even were transporting the cyclist mattresses around in a van around the Tour de France, and they would have their own mattress in the hotel room because they didn't want them sleeping on a foreign bed. So the attention to detail was there so that they could perform at their optimum. Well, that's essentially what we would do as check professionals, is we would look at every facet we can think of that could help, and give the tools for the patient to engage in their own process. So by working with all of these different factors, you chip away at it, and you gradually decrease the sensitization step by step by step. And across time, then the pain starts to subside. And of course, then it turns into a virtuous circle. If you start to think, oh, my pain's a little bit better, then your anxiety drops a little bit, your depression drops a little bit, you start to feel more hopeful. Your exercises are going better because the pain's less. Perhaps you're eating better, and that's allowing you to sleep better. And because you're sleeping better, you've got more energy to exercise. And, so it turns into a virtuous cycle if you can work on multiple different contributing factors.
Cool, very good. So now we probably don't have time for a long answer, but I'd like a brief answer to this question. Why do you feel that musculoskeletal medicine is perhaps failing quite a lot of people? And if you think that's a fair comment.
Well, it is. I mean, the research shows that musculoskeletal pain is on the increase. It shows that physiotherapists, manual therapists, surgeries, injections are on the increase. So, if we're doing it right, they should be on the decrease. So there's something going wrong. As we were talking with Paul Check about this the other day, and he was saying clearly we're barking up the wrong tree. If we were barking up the right tree, then you'd find that musculoskeletal pain is gradually dropping, and there's less and less of a need for physios and osteos and chiros and manual therapists of all sorts. But the opposite is happening. So clearly we're missing something pretty important here. And that was really the focus of the article, was that perhaps it's the ghost in the machine. Perhaps it is people's beliefs. It's their sense of their place in the world, what their purpose is. And the kind of holistic, integrated view of working with multiple factors, not just the nuts and bolts of the human body, but everything else that goes in to make you a human being.
So what you're saying there is that musculoskeletal medicine at the moment just isn't looking into all those areas.
Yes. Yeah. Well, do you know what? To be fair, increasingly it is, but the people that have been trained over the last 20, 30, 40 years, a lot of them are not. No, a lot of the people that are out in practice are not looking at those things because perhaps for whatever reason they're not keeping up to date with the literature. They don't have the tools to work with this kind of stuff. See, one of the challenges for manual therapists is that their toolbox is all manual therapy. It's all physical stuff. So if they don't have the training in psychology and they don't have the training in nutrition and lifestyle, that's kind of tricky for them to embrace that world without going and retraining. So I was very fortunate that I had the background in the naturopathy, which is that kind of world. And then, of course, the Czech system is the most naturopathic training I've ever done in those terms. So, the naturopathic model is to consider the body biomechanically, biochemically, psychologically, emotionally. And so that's essentially what we do with the Czech system. So for me, this information is kind of second nature and really exciting because we got the tools to be able to help with it. And, explains why we've been getting such great results for so long without being too sort of, self-congratulatory, I suppose. But no one's got all of the answers. But the point is that the more holistic we can be, the more effective we can be at helping people to help themselves. And that's really the key with this unconscious awareness, is that people need to take the responsibility, which literally means the ability to respond. I mean, I think that's a really important thing for people to understand. And if you're not taking responsibility, then you have no ability to respond. Therefore, you're disempowered, right? So the whole Czech system is all about giving people the ability to respond, giving them responsibility and allowing them to take control of their lives. And so again, psychologically, that's far better than giving them a pill or giving them a clip to their back or whatever it might be.
So my experience of people with persistent pain, their belief, and I could be wrong, but my perception of their belief is that if you're in persistent pain, it's just bad luck. What would you say to that?
Yeah, I mean, I think it depends on your life philosophy a little bit and whether or not you believe in luck. I think some people do seem to have bad luck. I would certainly say that I think we can all relate to that. You can relate to that in various aspects of life. Things don't quite seem to pan out for you. And for some people, those are big things. And some people, they're things like the England game last night. You could feel unlucky that they lost, but the point is that you really need to take the reins, and I think the sense that you're having bad luck is probably an indication that you are beholden to your unconscious drives more so than you recognize, or more than you recognize. I think Carl Jung has a quote, I'm trying to remember it off the top of my head, but essentially he says that until you make the unconscious conscious, your life will just happen to you, and you'll call it fate or something like that. So something along those lines. So, your life will kind of unfold in front of you, and you'll just say it's fate, it's bad luck. And that's often because we've got unconscious programming, we've got unconscious, what would be termed in psychological terms, shadow behaviors that keep us locked into a familiarity, but that familiarity is probably not serving us. If we feel like we've got bad luck and the results of our life suggest that, then I would say it's really time to go within, which is interesting because, in spiritual circles, they've always said that if you don't go within, you go without, as a just neat little phrase. But pain is something that comes from within. It's not, you have to go in to understand what the pain is. And so pain is a very subjective experience. It's not an objective thing. And we've used this objective model of saying, it's the disc causing the pain, or it's the joint causing the pain, or whatever, using an object to blame for the pain. But actually, the research is now showing it's the subject, it's the experience of the pain, it's the perception of the pain that's much more important. It's not that the object isn't there. Of course, if you smack yourself in the knee with a baseball bat, that's going to hurt. It's that there is an objective reality as well as a subjective reality. It's just that in musculoskeletal medicine, we've focused far too much on the objective as opposed to the subjective.
So that kind of leads me on to the next question, which you've touched on already, I guess. But I guess just to clarify what you were saying, again, imagine if someone's in pain. Yeah. Who would you say is responsible for getting them out of pain?
Well, I think there's no doubt that it has to be them that takes responsibility. But that doesn't mean they're on their own. And I think that's where, as any kind of healthcare professional or fitness professional, what we have to do is to meet the patient as an adult and treat them as an adult, and have you've probably heard of transactional analysis before, and I know you will have done, Leigh, but transactional analysis is the notion that we've got three different modes that we behave in. We've got the adult-child mode. So you can have a child-child conversation. That's like when you're being all silly with your mates and behaving like children. You can have an adult-adult conversation, which might be like two parents discussing which school their kid's going to go to. You can have parent-parent, that would be. You can have an adult-adult conversation, which would be, so for example, sex is something that a lot of medical professionals don't want to talk about because they find it uncomfortable. But sexual intercourse is a part of adult life that is involved, you could really exacerbate if you have sex in the wrong position with someone when, let's say you've got a disc bulge. So a lot of medical professionals would shy away from talking about that. And that shows that they're still behaving like a child in the clinic. You really need to adopt an adult disposition and sense of responsibility if you're working with people in healthcare. So the point is that, I suppose the societal model is that the healthcare professional is the parent and the patient is the child. But we want to try and bring that around so that we've got the patient as an adult, and we've got the healthcare professional as an adult as well. So they're having a conversation on a level. You're not, I'm not talking down to you and saying, oh, you're foolish for doing this, or you need to take this pill. I'm here as your coach to say, well, what do you think's wrong? Or what could we work on? What's the priority here? Here's some information. How does that fit with your experience? Okay, so it's all about education and being on a level with the patient. Of course, we've got more expertise in a certain area because that's what we've trained in and that's what we're interested in. But that doesn't necessarily mean it has to switch into a parent-child mode where you've got a kind of sense of hierarchy or dominance. I think it's really important for us to switch into that adult mode so that our patients behave as adults.
Okay, so
I think
yeah, well, it kind of leads me to the next question. Really. If you were someone in, or if you were talking to someone in pain, let's say you met someone in an airport somewhere, and they were in pain, what would be your advice to them?
Chop it off. No, it would. Well, obviously, it depends a lot on the kind of pain and on where the pain is. I suppose meeting someone in an airport, you'd want to sit down and have a long conversation with them to really understand what the pain's about.
Flight's delayed. It's okay.
But yeah. But I think, what I would do is I would try to understand what their experience is of the pain and how it came on and how they perceive the pain.
Well, I don't mean how would you fix them? I mean, like when they're going back home, what would be your advice to them to solve the problem?
Yeah, okay. Well, it would be to basically, there's one of the interesting things about health is extremely simple. It's disease that's complex, and so that's why it takes 7 years to train as a doctor, but you can train as a holistic lifestyle coach, which is a fantastic qualification in how to be healthy, in 3 days. Because health really boils down to 6 foundation health principles, which is to drink right, to think right, to eat right, to move right, to sleep right, and to breathe right. Okay, and if you can get those 6 things right, which is obviously easier said than done, then there'll be massive shifts in the way you feel and in the way you experience life. Now, obviously, that sounds simplistic. And there's another model that we use, of course, which is the 4 doctors. And we talk about the notion that there's only 4 doctors that you really need to consult. And one is Dr. Movement. So we talked about exercise and how potent that is. One is Dr. Quiet. So we've talked a bit about sleep and how sleep is key for not just for physical repair, but for mental repair. So when people are getting anxiety or depression or these things that can create descending drives, well, those things are massively impacted if your sleep's impacted. So particularly in the latter half of the night, if you're someone who gets up really early or can't sleep through the latter part of the night, well, that increases stress to the psychogenic repair, because most of your psychogenic repair occurs in that second half of the night. And so you might say, well, what can I do about that if I keep waking up? Well, Dr. Diet might have solutions for you there, because if you're not eating the right foods before you go to bed, then your blood sugar will rise up. Let's say you're having a vegetarian meal, or particularly a high sugar meal before you go to bed, but your blood sugar will spike up, and you'll then secrete insulin, which drops it back down again. And by somewhere around 1, 2, 3 a.m., your blood sugar is really low. So the only way you can bring it back up is to release cortisol, and cortisol is antagonistic to your sleep. So many people have insomnia and other sleep issues because they're just eating the wrong foods before they go to bed. And just simply adjusting their diet can be dramatically effective for many people. But also some people can't sleep because they're not exercising during the day. So they might need more Dr. Movement. They might need more Dr. Diet. And then Dr. Quiet works out. And once Dr. Quiet works out, then the last doctor, which is Dr. Happiness, comes online as well, because Dr. Happiness is all about getting your diet right, getting your movement right, getting your sleep right, and then you feel good about yourself. And the more you feel good about yourself, the more you want to move, the more you want to eat well, the more you want to sleep well. So they're all interrelated, those 4 doctors. And that would be a concept that I would suggest people go away and contemplate and read around. So, there's the 4 doctors, the last 4 doctors you'll ever need, ebook by Paul Chek. How to Eat, Move and Be Healthy by Paul Chek also covers all of this information, and the foundation health principles. So I would encourage people to look at those, because it doesn't have to get that complex. It can be quite simple, and you can make dramatic changes to people's lives and their health.
So those 2 resources are fantastic. What if people kind of need more help? What kind of profession or practitioners would you suggest people might seek for resolution to their problem?
Well, I would say that anyone who's a good manual therapist is likely to have either themselves the ability to work psychologically and nutritionally, or to have a team around them where they can refer to those kinds of people. Obviously, the check system that you and I have trained in and that we work in, that has the whole picture, as we've discussed tonight. And so, if there's a check practitioner, check trained professional near to where that person lives, that would be the first person I would point them to. Mainly because the check approach is so much about both empowerment of the individual, giving them active interventions. It's about looking at them about as holistically as you can get. I mean, that's why I love doing the training, because it was by far the most holistic and encompassing training that I could find. And I did a lot of postgraduate training, but this was the one that stood out head and shoulders above anything else. So yeah, I would say that's sort of your number one port of call. But beyond that, I would say, it could be a physio, it could be an osteo, it could be a chiro, it could be a sports therapist, it could be a massage therapist. There's many different people with hands-on skills and knowledge of pain that hopefully have a team around them that will be able to help. And of course, doctors as well. And there's some great surgeons around that will have these kinds of teams around them. But if people are trying to push you towards pills or to push you towards surgeries, assuming you don't have any emergency situations going on, then I would really question that. And I would perhaps look for a second opinion. And like I said, many Facebook groups around this kind of topic as well. So you can always get involved with one of those for additional support. Yeah.
And just to kind of add to that, if anyone does want to find a check practitioner near them, they can go to checkconnect.com, and check is CHEK connect.com, and then you can just search for a practitioner if you want to find someone near to where you are. The other thing I guess to mention is as well, some people can work remotely as well. So sometimes in some situations, people can seek help from someone who isn't local to them.
Yeah, that's true.
Me and yourself, we've worked with clients from overseas, and it depends. Sometimes obviously we do need to get our hands on people, but sometimes we don't, or we can work alongside someone else.
Yeah, I agree. I would say a lot of my work is often with other fitness professionals or health professionals, where they have a situation with someone that they're not quite sure how to address it. They want a different point of view, perhaps a more holistic point of view. And so I would assess the patient perhaps as a one-off, and then send them back to, so you might have people fly in from other countries or travel half the length of the country, but then they go back, and between their local practitioner and me or you or whoever they've seen, then you can manage the case effectively. So there's that. And then of course there's, like you say, there's Skype calls and this kind of thing. And much of the nutrition, lifestyle, beliefs, work around that side of things can be done remotely. And often, in conjunction with someone who's local that can do some of the more practical hands-on stuff. So yeah, that would be good advice for sure.
Fantastic. That's pretty much all of my questions, Matt. Do you have anything else that you might feel you need to add to anyone that's got persistent pain and just not getting the answers they want?
I think the most important thing is for people to keep exploring. One of the things I saw recently, which I found a little bit difficult to take, but I do understand that it could be beneficial in some circumstances, is the idea that acceptance is very important. And I think that's true, to accept the pain and to accept how it affects your life and so on and so forth. So that is one thing we haven't talked about. But my inclination as someone who wants to help people realize their potential is to not accept the pain, and to try to understand what it is that it is driving it, and what it is that it's teaching them. And sometimes it can be quite profound life lessons. So, it might be teaching patience. It might be teaching for people to have more compassion for others. There could be all kinds of different things that you can from the pain that you're experiencing. And that's not to say that that's the solution on its own, but if you combine that those learnings, let's say, with improving your diet, reducing inflammation in the body, getting better sleep, getting more exercise, breathing better, taking time to contemplate and meditate and so on, then that can have a profound effect on people. And I would encourage people not to give up hope in that way. I think there's always hope. So when we talk about acceptance, I think there's a kind of tightrope to walk there. That if you're too resistant and too doggedly determined, I'm going to fight this and fight this to the death, that might be a bit too extreme. I think to take more of this contemplative approach to it is a better way to handle it, as far as the research goes, and from my experience as well.
So I guess to summarize, in terms of the solution, it's about taking responsibility for yourself and really getting help where you feel you need it.
Yeah, for sure. And with someone that you can develop a rapport with, pretty soon on in the conversation whether you feel like someone's selling to you, or whether you feel like they know their stuff, or hopefully the discussion we've had this evening should give people some insight as to, if they're talking to a potential healthcare professional, whether or not that person really knows their stuff, or whether it sounds a bit woolly to them or a bit kind of old school. So that was one of the goals for this evening, I think, was to sort of educate people as best we could for the things to look out for and the awarenesses to have, so that they can pick the right team to work with. We can't do it all on our own. I think to have a bit of a team around you is important in any walk of life.
So I'm guessing the guy to your right behind you was a client who didn't do what he was told.
Yeah, he didn't follow the nutritional plan. But that's Cedric. Cedric has been my long-term compatriot since 1993. So he's doing well. He
doesn't say much.
No, he doesn't. But he has got a major leg length discrepancy, because one of my friends, school teacher, and took him to school, and one of the kids pulled the lower leg off, and it's never been fixed. So I often use him as an example. You see, a lot of manual therapists use what I would term diagnostic excuses. They'll try and find something that's easy to find. And again, I'm not saying that they're doing this consciously and trying to fool people. These are models that have been taught in manual therapy training for many years. But leg length discrepancy is pretty easy to find on anyone, or an apparent leg length discrepancy, let's say, because the body isn't perfectly symmetrical. And so I use it as an example. I say, well, look, this guy's had a leg length discrepancy and he's got no symptoms. He's got no joint problems. He's got no. So why is that? And it's because he doesn't have a nervous system, right? And so really what we're talking about here is that the whole thing around pain and around our life experience is because we have a nervous system. And so we need to do our very best to take care of that nervous system. So that's giving it downtime, it's giving it hydration, it's giving it nutrition, it's giving it movement, doing all the things the nervous system is supposed to do. And that way we can optimize neural function and minimize the risk of pain and dysfunction.
Awesome. I think we're pretty much out of time. There was one question from Debbie Miller. What we'll do is we'll answer that on social media.
Okay.
Just because we're purely out of time. But Matt, if anyone wants to get hold of you directly, how would they get hold of you?
They can look at my website, which is mattwallden.com, or they can email me on enquiries@mattwallden.com. So that's Matt with 2 T's and Wallden with 2 L's, WALLDEN. And they can probably find me on Facebook as well. So I know this obviously has been streamed on Facebook. So feel free to look me up there. I'm Matthew Wallden on Facebook. So that's how they can get hold of me. Yeah.
Fantastic.
I guess people can get hold of you too.
They can on Facebook. Yeah.
On Facebook. There you go.
I hope that people who are watching this and people in pain have, got some really good information, and, it's really going to help them move forwards. And Matt, I just want to really thank you for your time, and maybe we should do this again sometime.
Yeah, absolutely. Yeah.
I feel like we could have done this over a week rather than 90 minutes, but thanks.
So many directions you could go with it. Yeah, absolutely. But I think we got through the key components of it today, and some great questions. So thanks for posing them. Made me think a bit.
Yeah, cool. And thanks everyone that's tuned in, and Yeah, hope that was useful.
All right, great.
Take care, everybody.
Thanks, Leigh.
Bye for now.
Bye.